I want to talk about pain management, management of intractable pain, the pain that you can't find any way to get rid of, that's driving you crazy, and in many cases, it makes you just want to die. Physician-assisted suicide is one of the options for that, and we're going to get to that, but I want to go through several of the options that are used for intractable pain. So, let me tell you the story of two Dianes. The first Diane is someone I knew growing up, and as she became an adult, she started developing back pain, terrible back pain as she got older. It destroyed her career, it destroyed her family, it left her living very dependent on one of her parents, and she could do nothing, and nothing except think about her pain. Eventually, she finally negotiated with someone to bring her a pistol, and it's with that pistol that she went to the garage and ended her life because there was no other alternative for her. That's one Diane that I know. Dr. Timothy Quill writes of another Diane, a patient of his, and this Diane is one who had leukemia, and he was her patient over an extended period of time, but it became apparent eventually that her leukemia was going to overtake her completely. The pain was starting to get worse. It was less controllable. And so they started talking about the options. And while they didn't specifically talk about her ending her own life with the aid of her physician, they did talk about ultimate options in rather vague terms, kind of like Diane was protecting him from ever being complicit in her death. Well, as it turned out, he eventually wrote her a prescription for a sleeping medication, a barbiturate, and he gave her sufficient numbers of those as she could use it to end her life if that's what she chose to do. And eventually, that is what she did. With consultation with her family and in the presence of her family, she took the drugs and she ended her life. Timothy Quill is one that champions patient-assisted suicide, but he also says first we want to make sure all other options are tested before we advise someone to go this route. We have several definitions to work with here, and some of them may end up seeming contradictory, but let's look at them. If we go to a glossary, we find euthanasia, and that just means painlessly killing or permitting the death of someone who is ill or injured beyond hope of recovery. We have voluntary active euthanasia. That's hastening your own death by use of drugs or other means with a doctor's direct assistance. Passive euthanasia means hastening death by withdrawing someone's life-sustaining treatment and letting nature take its course. Now we call that AND, allowing natural death. Involuntary euthanasia is when somebody does it to you without your permission, either because you've lost consciousness or just never were consulted. And finally, physician-assisted death, notice carefully here, is the practice of a physician providing the means by which a patient may end his own life, usually a prescription for barbiturates, and the patient takes them himself, sometimes also called physician-assisted suicide, physician-assisted death, the same thing. But the important part here is that the physician provides the means, but the patient has to use the means and make it happen. Here's the landscape that has brought us to this point. We have a lot of people suffering from a great deal of pain, and palliative care, which means comfort care, not trying to cure any longer, but just provide comfort, and hospice, which means the care that we provide someone, non-curative care, within 6 months of their expected death. These have improved, Timothy Quill says, in terms of access and delivery. They are the standards of care for addressing suffering of seriously ill patients. But it is not sufficient for all patients. That's one of the things we're aware of. And we still have patients who die in a great deal of pain. And of course, I'll mention too that we still have many patients who never make it to hospice care because they are not referred there by their family or physician. So despite state-of-the-art measures, there's always going to be a small number of patients whose suffering is insufficiently relieved. Even in the midst of what we're calling an opioid crisis these days, we still have patients who are not getting enough medication or can't get enough medication to ease their suffering. And so they are looking for more extreme measures. These are the last resort options to relieve intractable suffering. Of course, aggressive pain management, which means with any kinds of drugs that we can come up with to block pain. Um, and of course, as part of it, we stop life-sustaining therapies. That is, we don't do anything that is designed to keep them alive any longer. They voluntarily may stop eating and drinking. And finally, we will do unconscious sedation, which means taking them all the way out of consciousness and leave them in that state until their body stops working and they die. So, should physician-assisted death be added to that list of last resort options? Maybe the last one, when none of those others work sufficiently, what do we do next? Some would argue, well, as long as we can sedate someone to unconsciousness until they die, then they really aren't suffering and the problem is solved. That, of course, is a judgment that an individual makes, and that's why we want to see if the fairest thing is to make all options available. Physician-assisted death, once again, providing a terminally ill patient with a potentially lethal prescription, usually barbiturates, that they could ingest on their own to relieve the otherwise intractable suffering by directly hastening their death. And note the terms, as I say, death and suicide are interchangeable. Sometimes suicide is preferred because it makes it clear that someone has not committed an act of euthanasia against the patient. Now, hospice is the specialized care, pain management care that is provided to someone when they are believed to be in the final 6 months of their life with their disease. And the majority of patients, though, who die in our country are never transitioned to hospice. They just are not referred there either because they don't want to give up, their family doesn't want to give up, the doctor doesn't want to give up, because it means we are going to stop treating to cure. We are going to say we cannot cure you. We're going to put you in hospice, keep you as comfortable as possible, give you the best quality of life we can until your life ends. So, should the disease-directed therapies be included with palliative care in a hospice setting? That's one of the questions people ask. Why not go ahead and go into hospice but still provide non-palliative care, care that's designed to defeat the disease from which they're suffering? And of course, the answer would be that's kind of contradictory. Hospice is about allowing people to die from their illness when we know that no additional interventions are only going to cause increased comfort. Remember our measure of burden versus benefit, that the treatment must not be of so much burden that it must not be of a greater burden than the benefit that is expected to be gained. And to provide curative therapy in that situation would be burdensome to the patient, as often believed. So even with the best case, though, there's going to be a small percentage where suffering becomes unacceptably severe. And we have to ask, what is the next act that we can take to do the best thing for these patients? Now remember our continuous ethics question. Ethics is figuring out the right thing to do. And while it may seem obvious to many that we go to physician-assisted death, there are others who say that can't even be put on the table. It's not allowable, it is an immoral act, and it's certainly contradictory to our religious beliefs. So lots of reasons out there that people argue for either using it or not using it. Timothy Quill says all last resort options, including PAD, make sense only if excellent palliative care is already being provided. We're trying the best we can with palliative care to alleviate the suffering. If we've done the very best we can and it's proved that that is not working, it's not going to work, then is the time that we can consider PAD at that point. These are some names of some patients you can research on your own a little bit. Janet Atkins is the first patient we know of. She was the first patient assisted in dying by Dr. Jack Kevorkian, a very famous name in physician-assisted suicide, eventually went to prison for it. He's now deceased, but he's the one that blazed the trail. Janet Atkins found him when she found she had Alzheimer's, early Alzheimer's. She learned about the disease. She knew she did not want the disease to reach its pinnacle, and so she found Dr. Kevorkian and arranged to end her life with his assistance before the disease got any worse. he had created a device that really is very similar to what we use in lethal injections in prisons, but it was one, in fact, where he set it up and it had a trigger, and the patient herself had to be able to push the button or pull the trigger. If she could not do it herself, then the event would not occur because the doctor could not do it. That would be illegal. That would be homicide in every state. So the patient has to administer the lethal drug. Brittany Maynard is a much more contemporary one, a younger woman, and we'll talk about her a little bit later in this presentation. We have a couple of other cases down here, and I'll let you look them up when you have time. Dax Cower was a young man who was terribly burned over most of his body, suffered immense pain, and constantly was asking to be allowed to die. They would not allow him to die. They continued treating him, and the treatment itself was extremely painful. Now today, even though he has recovered somewhat, the quality of life may not be what he wanted, but he still argues he should have been allowed to die. That should have been his choice because he was evaluated and known to have decisional capacity. There was nothing wrong with his mind. He just believed he did not want to live with his suffering any longer. Elizabeth Bouvier is another one. She was a quadriplegic and had some other illnesses that really incapacitated her, and she was weary of it. So she checked herself into a hospital and wanted to starve herself to death, but wanted them to give her pain medication as she went through the process. This went to court eventually because the hospital said as long as she's admitted, they can force feed her. And she was arguing they did not have to force feed her. Before it was resolved in court, though, she just changed her mind and left the hospital and continued living. This is about an initiative that was developed by the Center for Practical Bioethics in Kansas City a few years ago, and it's a project designed to educate physicians. They had some people that went out to educate groups of physicians around the country on how to manage pain for those who struggle with intractable pain, irreducible pain. And so it was trying to provide pain management, pain care that was consistent with the goals and values of the patient. The patient is always the one that makes the decision as to whether he's getting sufficient treatment, how much pain he has. Whenever we ask somebody to take a number on the pain scale, the patient is the one that identifies the number to demonstrate the level of pain. So this is a project to try to learn, to medicate, to treat, to care for patients consistent with their own goals and values. Of course, it did not include physician-assisted death, but it was trying to work on the continuum up to that point in options for treating the patients. Physician-assisted death has been expanding. It was passed in 1994 in Oregon, fully implemented, I believe, in 1997. And then you can see other states where it has been implemented, plus the District of Columbia. Montana is a state in which they don't have a law stating that it's okay, but there is no law that says it isn't okay. And so in a state Supreme Court case, it was ruled that physician-assisted death was allowable because there was nothing to prohibit it. Still, there are bills presented in legislatures all over the country every year wanting to expand PAD. It's a slow battle, as you can see by the dates there over the span of time, but in recent years it's been happening just a little more rapidly. Missouri and Kansas certainly are two of those states where bills are proposed regularly. But at the same time, in these other states that are listed here, there are people every year proposing bills to criminalize PAD to make it no longer allowable. So the battle goes on because it's very emotional to people because it reaches into their deepest values and beliefs. Other states have various approaches to it. 35 states actually prohibit it by law. And then 4 states aren't quite clear, and 3 states prohibit it by common law. And of course, euthanasia is prohibited in all 50. The Death with Dignity Act in Oregon has been the model for all of these other states. Everyone's bills pretty much imitates what they did in Oregon. So here's how it goes. It allows a terminally ill Oregon resident, must be terminally ill, must be diagnosed to be expected to die within 6 months. They can obtain and use prescriptions from their physician for self-administered lethal medications. Ending one's life in accordance with the law does not constitute suicide, euthanasia, or homicide, and they're very clear about that. They don't want somebody being criminalized because they helped you die. They don't want the patient to be stigmatized because they chose to die. So they're very careful about the language that is used. It specifically prohibits euthanasia, and as we stated a moment ago, that's prohibited in every state in the United States. And that's where somebody directly administers the medication intended to end another person's life. The kind of thing that we do with our animals when they reach a point in life where they can no longer live well. The Death with Dignity Act requires a patient to be 18 years old, must be a resident of the state, must have decisional capacity, and we've talked about that in the past, and have to be diagnosed with a terminal illness that will take their lives within 6 months. So, to request a lethal prescription, here's the process. The patient makes 2 oral requests to her physician, separated by at least 15 days, and then provides a written request to his or her physician, signed in the presence of 2 witnesses, kind of like the document for healthcare treatment preferences that you've prepared for your advance directive. Then the prescribing physician plus a consulting physician must confirm the diagnosis and the 6-month prognosis. And then the prescribing physician and consulting physician must determine whether the patient has decisional capacity to make this decision on their own. If either one of them believes that the patient's judgment is impaired, then they refer for a psychological examination. Finally, once everything is cleared, the prescribing physician then informs the patient that there are feasible alternatives, including comfort care, hospice care, pain control. And the prescribing physician must, but may not require, must request, but may not require the patient to notify his or her next of kin that they have requested this prescription. That's kind of like how abortion is treated in some states. They want to make sure somebody else is involved in this decision because it makes for better decisions, they believe. Here's Brittany Maynard. Now, Brittany, a 29-year-old young woman, recently married from California, stage 4 brain cancer, diagnosed in January. She dies by November of that same year. Knowing that her cancer was terminal, there was no treatment for it whatsoever, they immediately picked up and moved from California to Oregon to establish residency in order to gain access to the state's Death with Dignity law. And she ended her own life then with barbiturates prescribed by her physician on November 2nd. She received the prescription on November 1st and immediately the next day used them. So she had a plan. She was very open with everybody she knew. She wrote a long statement, 2.5 pages typewritten, single space that I've pasted on our website if you want to take a look at it. But here's a portion from it. She says, "Goodbye to all my dear friends and family that I love. Today is the day I have chosen to pass away with dignity in the face of my terminal illness, this terrible brain cancer that has taken so much from me, but would have taken so much more." She wrote this on her Facebook page, according to People magazine. As I say, her full statement is available to you on our class website. In 1997, then, as I say, when they finally implemented the law, Oregon became the first U.S. state to make it legal for physicians to prescribe the lethal drugs to terminally ill patients who met certain qualifications. Whenever this data was gathered 2 or 3 years ago, out of 1,100 who have filled the prescriptions, it's documented that 750 of them have actually used the drugs to die. So for many people, just knowing that they have the option, that there's something on the shelf in their house that they can utilize if it gets so bad they can't bear it any longer, but they never take the final act of taking the drug, ingesting the drug. So what principles are involved here that we've been talking about this term? We've talked about human dignity and justice as being essential if a person's life is to flourish. And human dignity really is essential to the Death with Dignity Act. Of course, there's the word right in the act itself. But believing that to allow disease to debilitate you beyond all control, and to take life away from you slowly, many people argue that is the contrary to preserving human dignity. Um, I refer to Immanuel Kant here that says you do your duty, you obey the rules. And of course, the categorical imperative that if an act I choose for myself is all right, then I must agree that it's all right for anyone else to choose in the same circumstance. These are the four principles of bioethics that are very common among people who are in healthcare ethics: autonomy, beneficence, non-maleficence, justice. We guarantee people that they can make their own informed, rational, coercion-free decisions about their health care. And when I say does the state have an interest, there are occasions like in the Cruzan case in Missouri back in the 80s where the state said they blocked the withdrawal of life support from Nancy Cruzan, a PVS patient, because they said the state had an interest in protecting uh, residents who were disabled and could not protect themselves. Ultimately, it went to the Supreme Court of the United States, and they were able, with a little bit more time, to get consent for her life support to be withdrawn. Beneficence, that means, is always doing the right thing for this patient, figuring out what's right for this patient in terms of quality of life and measuring burdens versus benefits. What benefit does the patient gain from continuing the burden of treatment and living with the disease would be the question asked pertinent to our topic today. Non-maleficence, do no harm. And of course, many would argue that to affect someone else's death in any way is to do harm, that is something that is not intended for us as human beings to do to one another, but we can't, and as well, we cannot do it to ourselves. But that's a controversial issue because some people would argue if killing in one place is all right, then why not at least doing it to myself? Do I not have that right? It's not always a sophisticated argument, but it's very present in the controversy. And finally, justice is just making sure everybody gets the same chance, they have access to the same resources, and that they are treated fairly in the healthcare milieu. One more topic we're going to cover this term very quickly, I'm going to jam it in this week, is on affordable health care, about asking the question if health care is a right that everyone should be guaranteed, if the government should be providing health care for everyone, and how that should be done. There are some important ethical issues there that I think reach into everybody's church congregation. And so I want you to have an opportunity to read a little bit and to be equipped to participate in that conversation when it comes to you. When we're looking to figure out the best treatment for a patient, we can use a method called the 4 topics method that considers these 4 topics here listed on the page, and here's the way it looks on a sheet of paper. You can see under medical indications, we're trying to figure out what's going on with the patient and what is the proposed treatment. So you can look at the questions here. Does the treatment fulfill the goals of treatment? Is it likely to be successful or is it futile? And what plan has been made in case of therapeutic failure? That is, that the treatment plan does not work, then what? Patient preferences. Do we know what the patient wants, and are we trying to listen to the patient's voice? Are we trying to ensure that the patient will have the greatest voice in determining what treatment he or she will receive? The patient's wishes have to reflect a process that's informed and understood and voluntary, or they have to have a surrogate who meets all of those standards as well if they can't make their own decisions. Do they have a healthcare directive? That advanced directive helps ensure their autonomy. Quality of life is very important. On that document that you filled out this week for your advanced directive, it says what is a sufficient quality of life for you to want to continue living, to receive treatment? Or do you know what quality of life is insufficient to endure treatment or cures that might be implemented for you? What is that level for you? Do you know the threshold on acceptable quality of life? And then a lot of contextual issues over here that include family and finances and religion, the law, clinical research opportunities that are out there, lots of other things going on in the environment that may create options for the patient or create reasons to behave in a certain way about decisions as they become aware of these features in the environment. So we always have the question, is there a fundamental right to die when and how you choose? That's an argument that has been part of the religious landscape for centuries, forever, because part of the argument is that if God creates, only God can take life away, and we don't have the right to do that ourselves. But of course, it's a controversy, which means there are arguments on both sides of that question. If our goal is death with dignity, in the context of intractable pain, is physician-assisted death or suicide the only way to achieve death with dignity? What other means are there that you would accept as a death with dignity for yourself or for your loved ones? And then, of course, we talk about autonomy. What justifies a limitation to your autonomy? Uh, when is paternalism justified? When can we say that the doctor knows better or that your family knows better than you do and they deny your right to make your choice, as they did with Dax Cowart back in 1973? I referenced Daniel Callahan here in the Netherlands. That was for another presentation I made, but you can look that up and find a little more information on how Callahan references the law in the Netherlands for how we handle this issue in the United States. So the question is, do families, do loved ones have the right to intervene and say, no, he may choose this, but we don't agree and we don't consent? Does your family or anyone else in your life have the right to withdraw consent from allowing you to end your own life? That is really the question that's at stake. So we'll continue looking at this. We're going to look more at healthcare accessibility. And then the third issue that we've already done is around critically ill newborns. And I tried to extrapolate that over to critically ill adults at the other end of the life spectrum. We just don't have time in a week to cover everything we'd want to, but I thought these are three issues that get us thinking a great deal about the state of healthcare in our country, what some of the burning ethical questions are today as people keep engaging healthcare and trying to make their own decisions about their healthcare. So that is it for today, and I will create opportunity. I have created opportunity on the website for you to enter a conversation on this. Another forum it's optional. It's not required that you participate, but if you'd like to get into the conversation with one another on forum, I will join you in that as well to talk about physician-assisted death, whether it's viable, whether it's allowable, how we should regard it as an option. But that's it for now. Thanks.